growing weary of running from room to room, practicing one-tooth insurance-driven dentistry? Then stay tuned for the latest episode of The Lionhearted, where Dr. Stephen Rasner will hand you the blueprint for what many call the gold standard of general practice dentistry.
Hi everyone, welcome to The Lionhearted Dentist with Dr. Steve Rasner. You know, sometimes I come on here and I can tell that you know that I'm more excited about a subject that I want to share with you than other times. Well, that's this podcast. Okay, I am excited because I'm positive it's an easy concept for you to assimilate. It's going to have a dramatic impact, I believe, on many of you listening. So I'm not going to waste any of your time. I'm going to give you my email. It's my name, Dr. Rasner at AOL.com. Thank you to those of you that continue to write to me and those of you that listen from around the globe. It means everything to me. And quite honestly, it's an honor to come into your lives once a week or every couple weeks or once a month, whatever it is with you, and hopefully share with you something that you're going to look back on one day that makes a big difference. And this one I'm about to tell you is one of them. It involves my absolute favorite topic to speak about, and that would be case acceptance. Okay? I know the reason many of you do not have high enough case acceptance. You ready? And I know for one of you listening that this is absolutely going to resonate. And it's because you give too many treatment planning options. Stop for a minute. I want you to think about this, what I just said. You go in at the moment of truth, and you're not sure what you should do, or you're uncertain that what they should do conflicts with what they want, and so you give a half-hearted recommendation. Okay? I'm going to help you change that. We're going to look at several very simple parts of this process where I think you're continuing to make such a mistake. So, and I know this is true, what I just said, for many of you that have written me over the years, including lately. But think about it. I want you to think about it for a minute. Think about the times that you went to get a computer or some type of appliance for your home, and you really didn't know what you wanted to do. This has happened to me, or even a car. And the person informing you confused you by giving you way too many options. So what was the end result? You didn't purchase. You didn't buy. If you really think about this aspect of the lion-hearted dentist that I pontificate week after week, think about it for a minute. Stop and think about what I'm about to say. So somebody's going to get up this week, wake up in their home, and during that day, they're going to telephone your office based on what they've heard, hopefully. Hopefully it won't just be a quick Google search, and that's why they came to you. I'm not saying that's a horrible way to get patients, but I'd rather have a word-of-mouth patient any day of the week. And the only way to get word-of-mouth patients is to earn them. And the quickest way to earn them is to sedate them. I'm not kidding when I say that to you. That's why you hear me over and over again talk about the advantages of incorporating that into your practice. But let's put that on the side for tonight. So then they call you, and they come in, and they go through whatever process you have implemented in your office. And I have to ask you right now, do you have any process? What is the protocol in your office when they pick up the phone, call you, when they come into the office, and let's say you have a great one, and then they go back in the operatory, and they're have an impeccable set of x-rays taken by somebody with a great gift that doesn't gag them and has the gift of gab, by the way, while they're taking this full mouth x-ray. And they're likable, in other words. So it's all a 10 by the time you walk into the room. And let's say you even have the significant other there, because as I have tried endlessly to share with you how important a second pair of eyes and ears are when the new patient's indicated need. And then you listen to what their chief complaint is, and then you start espousing options. And I will tell you that there's an absolute inverse proportion of case acceptance to the number of options you give them. And if you think about that, that is hardly profound, what I just said. If you give a new patient 2 or 3 options to treat something, they're going to go home and think about it because you've confused them. Why did you do that? I know why you did that. Primary reason you did it is you weren't sure what the treatment plan should be. And, you know, I do have to say, if you don't know what the treatment plan should be, then don't offer a treatment plan. Either refer the patient or take the time required to work up the information that often we have to work up. Not that often in my office and many other offices, because I'm going to tell you something you may not want to hear. The longer you're in practice, the better you get at this. The other thing that will shorten that road for you of getting good at treatment recommendations is CE, abundant CE. Ladies and gentlemen, sorry. Does this sound all familiar to you? So let's go back. So what do you do? Well, the first thing you do, assuming you have everything else in place that I speak about. So at the point that you have walked in, the patient's had a pretty good experience. And you walk in and you commence with a new patient visit the way I've spoken of. You ask them how they found you, because that often sparks confidence in you if it was somebody they were referred by that you've done nice work on. It may just be a single crown. And maybe that patient, prior to you, the other doctors couldn't get them numb. Do you think this is all pie in the sky? Do you forget that 1 out of 5 inferior alveolar blocks are missed the first time that the doctor delivers it? And how many patients have told you that they had 14 shots or something at the last office and it still hurt? So we've all heard these stories, but maybe you just did a very small treatment plan to somebody and you got them numb with the first or second shot and it was no big deal. So they referred you another patient. So it doesn't always have to be this masterful case. That said, sedation practices, oral sedation, encourage others to refer to you greater than any other service that you'll provide. But let's go back and let's say we're going to follow my recommendations. That you've heard their chief complaint and you're now going to look at those 5 areas that you've heard me speak about. And if you're tuning in for the first time, they are covered in great detail in my very early podcast. And I repeated my approach to the new patient exam many times. But this is why right now it's important. So the first thing we're going to look at is the health of their periodontium, no matter what they said. And I've explained in this earlier podcast why that's a good approach for the patient to have you take. It's not manipulative. It's the intelligent order of things to be done, no matter what their chief complaint was. They didn't come in and tell you they had bleeding gums, but that's the first thing you're going to look at, the health of the periodontium, for the reasons I've explained earlier. And let's say there's a problem. How about if this patient wanted you to improve their smile? They wanted veneers on their front 2 teeth. Isn't that what they always want? They're shocked that it's to impact a smile. It has to be 8 or 10 or certainly 6. And you begin to examine the patient, and the first thing you see is multiple areas of, let's just call it incipient bone loss, and in some areas, moderate bone loss. And this patient doesn't have any idea about this. I would find it hard to believe that anybody listening right now would not pause at that point in their mind and say to themselves, there's no way that this can be part of this exam. Of my treatment recommendations. There's no way that I can go forward and feel good at this point. We're talking about changing someone's smile when there's active periopathology going on in their mouth. That's a game changer. That's step 1. Let's say it was good. Okay, great. Let's go to step 2. How is the health of all their hard tissue, their teeth? Are there unknown pathologies? Certainly, though many of you listening have had a patient come in. I can't help but think of a neurologist that came to me and wanted me to fix one tooth in his smile zone. And when I went through the exercise I'm doing with you, he didn't have perio, but he had 3 areas of periopathology untreated in his mouth. I was incredibly uncomfortable breaking it to him. And by the way, this guy did not pursue treatment with me. But no, I'm not going to. That wasn't a smile makeover. That was a 1-tooth fix-up request. By the way, you can agree to disagree with me. This is my approach. Because at the end of my approach, I am able, based on the 5 things I'm looking at, to almost always make a recommendation with conviction. And a recommendation with conviction would sound like this. I've done my exam. I've taken my notes. Sometimes I've stepped back and stopped in the middle of the exam to get more information from the patient. So I'm actually examining them laid back with gloves on, the whole bit, set them up, took all my PPP stuff, my protective gear off, and got more information from the patient because I know to get to what they wanted, this was going in a different direction. You understand? I don't think this is confusing. The third thing I'll look at is a combination of muscle, joint, and parafunctional wear that the patient may have. So let me say to you again, let's take the patient that wants a smile makeover. And let's be honest, for many of us, the smile makeover often in the patient's mind does not include enough teeth that need to be restored as the patient thinks has to be restored. But let's say they came in with a collapsed VDO, collapsed vertical. And part of that reason is because they're missing posterior teeth on one of the arches, that they are brachiocephalic, and they have parafunction everywhere. Can you, at that time, be comfortable treating 4 teeth, 6 teeth? Though it might look good, they might look good walking out of your office, but you're going to have one very strong negative referral source down the road by going through. Do you see how the process is happening? Okay? Then I look at, are there missing teeth? And is that related or needs to be addressed given what their chief complaint was? Sometimes, very often it does not. Very often I'll have a patient that we they're missing a first molar. And that's the way it is until a later phase of treatment. And shoot me, sometimes forever. Maybe they're missing a couple teeth, but they don't have power function, and everything else seems pretty healthy. So it's not a problem to me. So remember what I'm saying to you right now. I do realize there's a great advantage to having 40 committed years in dentistry as I do. And naturally somebody I don't think out the first year or two might be as quick. And if I wasn't, then I would not give the treatment plan on the opening day. Now, what's the disadvantage to that? Absolutely get less treatment acceptance. But if you don't know the treatment plan, you can't give it on day one. Okay? So I will tell you that the process kind of guides itself if you go through it the way, like I'm not looking at a manual that says step one, examine their gums and periodontal health. I mean, there's 5 major things that I look at. And there's other things I know about, like you know about. Their diet, their social history, what's important to them. I've had discussions, that opening discussion with this patient can be 2 minutes or it can be 10 minutes. Especially in my practice where people have come with often a history of fear and bad past experiences. So again, I know wasn't supposed to be part of this podcast this week, but having a practice that focuses on oral sedation attracts people with similar backgrounds. And it becomes very familiar and easy for you to take a route based on what you're hearing. I'll give you an example. Somebody came in today, a patient that, with her mother, she's mentally challenged, had a very, I can't think of the proper word, so forgive me. She functions very, very well. And even went to high school and graduated through a special program, that kind of a patient. And had severe gagging complex. Her initial treatment plan for me with her mother there was to get rid of the pathology. It did not even include tooth replacement, which, by the way, it may never include that, because I don't know whether anyone will be successful with this patient with the gag reflex that I believe she has. I don't even know if I'll be successful with taking her teeth out based on the time I was with her today. So that is a treatment plan. I didn't go into automatic tooth replacement. Very unusual, because it was obvious to me that this patient is going to be very challenged. Is macroglossia to an extent that could be in a textbook. So I don't think anyone's going to be successful with her. And it just did not seem appropriate at 55 years old. She was not malnourished to even speak about implant dentistry. I did offer them the option of going to an oral surgeon or any place that IV sedates patients. So that was a very specific patient-tailored treatment plan, which often many of them are. So, as I'm going through these things, now let's take a quick opposite approach. Let's say they didn't have these things. There was no periodontal problems, or maybe they needed a scaling for gingivitis. There was no bone loss, just inflammation, supragingival calculus, etc. They had no muscle or joint pain, no significant wear. What did they have? They had some sensitivity around some old restorations. And let's say that this is a common patient for me, they had amalgam restorations in every quadrant, and poor ones. But there was no PA pathology on the x-rays. There was no need for you to deal with perio, occlusal problems, missing teeth issues. This is my approach to that patient. Sensitivity on the upper right is what brought them to me. My approach would be, first of all, I would like to tell you, Mrs. Smith, that I could justify doing multiple, what we call quadrants of dentistry on you. getting rid of a lot of those amalgams. And I'll go into what that restoration looked like the day it was placed, where it was flush with the margin of the tooth. Patients can relate to this. And there was no gaps. And now we're 20 years, maybe more out. And there are gaps. And there is recurrent early decay at that. Why don't you do this? What I would do, there's some mouths I can go slow with. I would do your whole quadrant. Why would you do one tooth? And in that quadrant, I'm going to try to be as conservative as I can. Now, I can tell you already on 2 teeth, I can't be conservative. I have to do what's called, which you've never had, full coverage crowns. That means I'm going to completely cover, and I go through what the process is. I tell them right on the spot. I said, there's 2 other teeth that I think I can do direct fillings on. I'm giving you this simple example on purpose. So, I always say to the patient, I say to myself, the mouth will tell you a lot about it if you watch it carefully and you examine it carefully. Have you ever had a patient that had 80% of their mouth teeth blown away? They needed endos, they needed removal. I'm talking about due to decay. But for some godforsaken reason, they might have had 4 teeth in each arch that endured the war, as I call it. They survived the war. They were okay. And I tell the patient just like that. I said, I think those teeth are worth keeping. I know in your mind you walked in here, you told me you wanted your teeth out to have a denture. All of those of you listening right now have been in this scenario. They have 4 teeth left on the top. Maybe it's 2. And what do I do with that patient? Well, if it was 2, unless they accepted implants, I would still tell them, I am so anti-full denture prostheses that it's another 5 podcasts to tell you about it. I might even retain 2 teeth if they were bilateral and explain to the patient that you never know what's down the road. And if there was nothing wrong with those 2 teeth, and I know that may sound unusual to some of you listening, but I don't think, I run into many, many scenarios in this career of mine. I think more of the point is as follows. Let's keep it simple if you can. Okay? If you can treat quadrant dentistry, then absolutely treat quadrant dentistry to a new patient who's never reached into their pocket. They're about to trust you. They've gone to an insurance-only dentist that does 1 crown a year, and at least you have the opportunity to take 1 quadrant and make it your quadrant. Make it beautiful. And I always tell a patient that less is best. That although they don't have any crowns in their mouth right now, or scratch that. Let's say they have 1 crown with a root canal. That to me is a justifiable, legitimate point, a time to say to the patient, you see that 1 tooth over there where you've had a crown and a root canal? And I'm pointing to it on the screen. What if we had gotten to that before it needed a root canal? You wouldn't have gone through the root canal. You would have saved considerable money. Of course, a crown tooth can always end up needing a root canal. I get it. But why, right now, when I know that is the situation, why would we possibly try to fill that when I'm inviting failure? I'm inviting more cost and time for you. And I don't know if you're getting this over the sound waves or if you're watching me right now. They can feel that I'm telling them the truth, because I am. And then listen to your gut. If you're not sure of something, like whether you can restore a tooth or not, it needs root canal, and the decay looks like it's to the bone, and you don't do orthodontic extrusion in your office to pull enough tooth up to have an effective furrow to crown, then don't do it. On anything. If you're not sure, listen to your gut. That's how I teach surgery. If you're not sure of the patient, no. Don't. As soon as you feel that, the answer is no. It'll protect you. It's the right way to do it. So, I hope this helped some of you this week. I'm trying to get you to be more convicted in your solutions that you're offering. Try to keep things simple. Look at the key flags that'll get you in trouble. Is it a periodontal patient? Well, you all know that. Is it an occlusal wear? Brachiocephalic, as I said earlier, there are bruxer, you can see a mile away. Well, either you're going to sandwich a single crown into that maloccluded dentition and tell them that. You certainly can't improve their smile without reopening up their vertical, which is a total commitment. I get it. Pay attention to the red flags. If you don't have any red flags, try to take it in simple quadrants and let the patient gain confidence in you. I treated many patients from 1990 to 2010 and restored all 4 of the quadrants over time. Lots of it with gold, by the way, that have very functioning mouths to this day. It is very rewarding and very fulfilling. Hit me with some questions, guys. Dr. Rasner at AOL.com. I hope this helped one of you. If you want me to elaborate, then write to me. Have a good week. See you next week on The Lionhearted.